Okay, we're going to start our head to toe complete physical exam. My patient, I would observe his gait walking in the exam room, and that was normal and appropriate. To start with our mental status exam, I would assess his level of consciousness and orientation. That is alert. He's alert and oriented times 4. He's in no apparent distress. I would be paying attention to his height and build. I would be looking at his hygiene and dress, which is appropriate for the weather and time of day. I would be looking at his speech pattern and language. I would be looking at his memory, attention, behavior, mood, general affect, and everything seems to be in order. Next, we're going to be doing the cranial nerves. First, I would start with number 1 is olfactory. In the clinic, I would occlude each nerve and provide him with a familiar smell that he would identify, and we would do that bilaterally. Cranial nerve 2 is optic, and with that, we're going to test his visual acuity with the Snellen chart at 20 feet and the Jaeger chart for up close. I believe that one's 14 inches. The color discrimination, and the cover test. So I'm going to have you cover an eye with your hand. Can you tell me what number? Just look at my nose. Tell me what number this is.
2, 2, 1.
Okay, and we would do that bilaterally. And then the let's see. Cranial nerves 3, 4, and 6 are oculomotor, trochlear, and abducens, and that I would also do the 6 cardinal movements. So I'm going to have you look at my finger, follow my finger with just your eyes. We'll do convergence right now here. I'll follow my eyes in. Good. And those follow, and they're symmetrical. And then we'll also do the cover test here, where I would just cover an eye. Go ahead and look at my finger, and I would watch that eye that gets uncovered for any abnormalities, and I would do that bilaterally. So let's also do the, it's some kind of reflex, I can't remember the name right now, and that looks good, it's symmetrical. And corneal light reflex, I think that's what that was. So cranial nerve 5 is the trigeminal. For sensory, we're going to test his ophthalmic area, maxillary, and mandible area with light touch, and that is intact. And then I will also palpate his masseter. I'll have you clench your teeth, and then can you move your jaw side to side? Good. Open and close. Great. And then 7 is the facial nerve. I'm going to test that. We're going to test the anterior 2/3 of his tongue for the taste. So sweet, salt, sour, and bitter. And then I'm going to have you smile, show your teeth, frown, raise your eyebrows, puff up your cheeks, and whistle. And that's intact. 8 is acoustic. I'm going to do the whisper test first. I'm going to cover his ear, and I want you to repeat what I say.
Tuesday.
Good. I would do that bilaterally. I'd take my tuning fork, and we're going to do the Weber test. I would expect lateralization for that. And then the Rinne test, I'm going to apply my tuning fork to his mastoid, and then when that is no longer heard, I will put it next to his ear. And that's proving that air conduction is greater than bone conduction, and it's a 2 to 1. 9th is glossopharyngeal. I'm going to have you open your mouth and say ah.
Ah.
Good. I'm looking at his uvula, and his palate rises symmetrically, and so that's intact. Let's see, that was 9. 10 is the vagal nerve. I would elicit a gag response with like a tongue blade or tongue depressor with that. 11 is spinal accessory. I'm going to have you shrug your shoulders against my resistance. Good. Turn your head to the left, right, side, lateral side, again, and then front, Back. Good. And then the 12th nerve is hypoglossal. Go ahead and stick your tongue out and go side to side, up and down. And that is midline and good. So next we're going to do actually no, we're not. We're going to continue with our neuro assessment, and we're going to check primary sensation. I'm going to have you tell me with your eyes, go ahead and close your eyes. Tell me if this is light, dull touch, or sharp.
Dull. Dull. Dull.
Okay. And then I'm going to do 2-point discrimination. Tell me, close your eyes, tell me if this is 2 points or 1.
2. 2.
Good. And then we're going to do our vibratory response. So with that first one, the primary sensation, I would do light touch throughout. We can do temperature, and we can also do sharp or dull if we were concerned about that. Vibratory response with my tuning fork, I'm going to start distally on the joints and work in proximally, and I would just have the patient verbalize if he can feel those, and he can. While I'm down here, we're going to test for peripheral neuropathy with my monofilament, and I'm going to have him close his eyes, and I will be pressing on certain areas of the foot, and he would indicate if he can feel that or not. And that is that. While I'm down here, we're going to do position sense. Tell me on the great toe, close your eyes and tell me if your toe is up or down.
Down.
Good. Up or down.
Down.
And then fingers, we'll do this bilaterally. Up or down.
Up.
Good. Then we're going to do, let's see, stereognosis. I'm going to have you close your eyes. I'm going to put a familiar object in his hand, and I would want him to identify that.
A ring.
Good. And then next we'll do graphesthesia. I'm going to write a letter or number in your hand, and I want you to tell me what it is with your eyes closed.
8.
Good. Then, I think that's it for that. I'll have you go ahead and stand up. And I want you to bend down. We're going to assess his, just squat. We're going to test his knee strength, leg strength. Good. Stand up. And then we'll have you, I want you to walk this way on your heel to toe. Good. Turn around. Walk on your toes. Great. And then walk on your heels. Perfect. And then I want you to move your, heel to from your knee to your ankle on each side. Good. Good. Now go ahead and with your arms, actually just stand here for a little bit. Close your eyes with your feet and your hands together. I would look for swaying. This is the Romberg sign. I'd watch for 20 to 30 seconds. Next is the pronate or drift. Go ahead and put your arms out, palms up. And with his eyes closed, I would want to want him to keep supinated. And if he starts to pronate or drift down, that would be a positive sign. And then last, go ahead and sit here. You could lay down this way, please. Next, I would do the meningeal signs. I would have him, the Brodzinski, I would lift his head and shoulders, and a positive sign would if he involuntarily flex his hips or knees. And then the other one, go ahead and lay back down. The Koenig sign, I would have him put his hip and knee at a right angle, and then I don't think that's right. What's the Koenig sign? Let's look quick. Koenig sign. I don't know what the Koenig sign is right now. I think any pain or tender or resistance straightening the leg would be a positive Koenig sign. So we got that. Go ahead and sit up. So that concludes our neuro assessment. We're going to do the integumentary system now. And I would start by looking at the patient's skin. I would be looking for lesions, moles, any edema, ecchymosis, erythema, scarring, tattoos, piercings, and things like that. If I did find a lesion or mole, I would use the ABCDE method. So I'd be assessing asymmetry, borders, color, diameter, and elevation. Next, I'm going to palpate his skin. His skin is warm and dry, so I'd be looking for temperature and moisture. His turgor and texture is appropriate. And I would also be looking at his hands and fingernails. I'd be looking for contour of the nail, any abnormalities or deformities. I'd be looking for pitting, clubbing, and everything looks good here. Then I would be looking throughout the assessment. I would be looking at his hair color and distribution on his head and body, and I would just be mindful of that. And then I would be looking through his skin as we do our exam. So next we're going to do the head exam. I'm going to be looking at his head and face for symmetry and deformities, looking for edema, masses, erythema. I'm going to palpate his hair and scalp and looking for the distribution of hair, any other problems, edema, tenderness, masses. Face, I'm going to be, again, assessing all of those same things, looking at the bony structures, and I'm going to palpate the patient's face. I'm going to palpate the temporal artery pulse, and that's 2+. I'm going to palpate the temporomandibular joint. Go ahead and open and close. There's no tenderness or clicking with that. I would also palpate his frontal and maxillary sinuses for tenderness, and there is none. Next, we're going to move on to the eyes. I'm going to be looking at his eyebrows and eyelashes for uniformity, symmetry, distribution. There's no masses, lesions, or discharge seen. Upper and lower eyelids are intact. There's no erythema or edema. Conjunctiva is pink and moist. Sclera is white without icteration. The pupils are equal. Go ahead and look at me. And they are 2 millimeters in diameter. The iris is symmetrical and hazily looking. Next, I'm going to do look at his pupils a little bit more here. Go ahead and look at my finger. His pupils are round, reactive, equal to light, reactive to light, and direct and consensual accommodation. We already did the convergence and confrontation. I'm going to do my fundoscopic exam next. So we would do this bilaterally. I would be assessing his left eye with my left eye, my right eye with his right eye. So I'm going to first start by finding the red light reflex. This is all out of whack right now. Go ahead and look forward. And I would follow that red light reflex in, and I can see that the optic disc is sharp with good margins. The vascularity is normal. The retinal background is red-orange. The macula is present. The lens is clear. And everything looks great with that. Next, we're going to look at the ears. I'm going to look at the ears and palpate the helix, auricle, tragus, and the mastoid. I'm going to pull the pinna up and back for adults and down for children 3 and under. I'm going to take a peek at the canal. I'm looking for cerumen, discharge, lesions, and foreign objects. Then I'm also going to look at the tympanic membrane. It is gray, pearly gray, translucent, no bulging or perforation. The landmarks are present. I can see the umbo, the malleus, the long handle, and the rim. Next, we're going to look and palpate the nose. The nose is without edema or erythema. I'm palpating for tenderness or masses. We'll take a peek in the nose here. The septum is midline, there's no deviation. Turbinates are present without edema or erythema. There are no polyps, and there is no discharge. Next, we're going to take a peek at the lips or the mouth region. Starting with the lips, I'm looking at the border, moisture, color, and any lesions, and that looks good. I'll have you go ahead and open your mouth. I'm going to be looking at the buccal mucosa, the hard and soft palate, the tongue, the lips. Everything looks pink and moist. Go ahead and stick out your tongue. Say ah.
Ah.
Good. Tonsils are 1+. The posterior pharynx is pink. There's no cobblestoning or edema. There is no broken or missing teeth. There's no dental caries. Go ahead and lift your tongue. The Wharton's and Stenson's duct is visible. I would also take a tongue depressor and a gloved hand, and I would look at all areas of the oral mucosa, all sides, lateral sides, all sides of the tongue, looking for lesions or masses. And I would also do a bimanual palpation with my gloved hand on the tongue to identify any masses or nodules or tenderness. Next, I'm going to be looking at the neck, looking at size, shape, any deformities or abnormalities. On palpation, the trachea is midline. There's no abnormalities there. I'm going to palpate the carotid pulse right now. We'll do that bilaterally at different times. And that's 2+. I'm going to check for the thyroid. Go ahead and swallow. Good. The thyroid is smooth and firm. There's no nodules or tenderness palpated at this time. I'm going to do the sniff test on the nose here. I'm going to occlude each nostril and have the patient breathe. Blow out. Good. And that is patent. There is no odor to the breath. And we will move on to the lung assessment. So on the anterior and lateral sides, I'm going to first inspect the lungs, and I'm going to inspect my patient, his general breathing. His respiratory rate is even and without difficulty. His respiratory rate is 16 right now. Minimal effort with breathing. He's using no accessory muscles, and he has no retractions. And of course, I would have him without a shirt on to assess that. Next, we're going to palpate in the second intercostal space, the aortic area. Again, second intercostal space, the pulmonic. Third to fifth intercostal space on the left sternal border is the tricuspid area, and then the mitral area is that fifth intercostal space on the midclavicular line. And that's good. There's no pulsations or thrills with that. Next, I'm going to percuss throughout. And I'm percussing resonance. Go ahead and lift your arms for me. Great. And next we will auscultate. I would have my patient take a deep breath in and out with my diaphragm, and I'm going to be checking this in a lateral type pattern, a ladder pattern. I'll have you lift your arms. Good. Next, I will Next, I will do identify landmarks here. So we have the clavicle, sternum, the suprasternal notch, the manubrium, the angle of Louis, the xiphoid process, the costal margin, the midsternal line, midclavicular line, the supraclavicular line, infraclavicular, supraclavicular, infraclavicular. I'll have my patient go ahead and turn this way a little bit here. Just turn so I can look at your back. Okay, next we're going to, again, assess the posterior thorax. I'm looking for any masses, tenderness, lesions, any abnormalities in the spinous process, any bony deformities. I'm going to percuss. And I am getting resonance throughout with that as well. Okay, next we're going to check for chest expansion on the 10th, at the 10th intercostal space. I'll have you go ahead and take a deep breath. Good. And that chest expansion is symmetrical. I'm going to check for diaphragmatic excursion. Go ahead and take a deep breath in. Okay, take a deep breath out and hold it. So his diaphragmatic excursion is about 2 centimeters, which 3 to 5 is normal. So I'm going to do that again. Go ahead and take a deep breath. Out. And it is about 3 centimeters. I'm going to check costovertebral angle tenderness. Go ahead and let me know if you have any tenderness with this. Anything?
No.
Good. Next, I'm going to auscultate with my diaphragm. I would again have my patient breathe in and out. I would avoid bony prominences. Good. Next, I'm going to do the whisper test. I'm going to have you whisper 1, 2, 3. This is whisper petriloquy. Go ahead and whisper. Good. And that's kind of inaudible and distant. Next is the bronchophony. I'm going to have you say 99.
99. 99. 99. 99.
Good. And that's indistinct and muffled. Last, I'm going to do the egophony. I want you to say E when you feel me hit with this, or press with the stethoscope. Say E.
E. E. E. E.
Great. And that, I can hear an E. If I were to hear an A, that would indicate abnormality or consolidation in the lungs. So that concludes our lung exam. Next is cardiac. I'm going to first listen while he's sitting up. And I'm going to listen to those same areas, the aortic, pulmonic, tricuspid, and mitral. His heart rate is 68. It's regular in rhythm. There's S1 and S2 is present. There's no S3 or S4 audible on auscultation. There is no clicking, splitting, murmurs, or rubs auscultated. So now I'm going to have him lay down, and why don't you just go ahead and lay down this way so we can see your upper body. Okay, no, lay on your back. Great. So next we're going to look at the, we're going to inspect his chest. And with that, I'm first going to be looking at his carotid pulse. And that's 2+. There's no venous distension, jugular venous distension noted. I'm going to look at his, jugular venous distension, jugular venous pressure. So I would have my patient's head up at a 45-degree angle more. I would be looking at that highest point that I can see the pulse. Go ahead and look to the right a little bit there. There it is. And then I would have a straight edge going straight out and then measure, and that is 1 centimeter or so, and we want that less than 3 centimeters, so that's appropriate. Great. Next, I'm going to look at the chest. I'm going to palpate the pericardium and the precordium. And I'm going to look at the PMI, which is the point of maximal impulse. I'm looking for any lifts, heaves, or thrills, and there is none, and I can feel that PMI at the 5th midclavicular line, sorry, the 5th intercostal space at the midclavicular line, which is great. I'm also going to note that on my lung percussion, I had resonance, but there was some dullness over the cardiac, or over the heart. So next we're going to palpate the heart border. I'm sorry, not palpate, percuss for the border. Good. And that's good, and there's no displacement of the PMI or anything like that, so that's great. Next, I'm going to listen with my bell and my diaphragm in all those same areas. And again, I already told you my exam with that. So that looks good. Let's see. I'm also going to listen for bruits with my diaphragm, or with my bell. I'm going to listen to the carotid for bruits, the aorta, the renal pulses, the iliac, and the femoral. And there's no bruits there. So that is good for our cardiac system. Next, we're going to do our abdomen. First, we're going to inspect patients. I'm going to be looking at the color of his abdomen, placement and color of his umbilicus, and that is midline, and it is the same as the rest of his skin color. There's no pulsations or any peristalsis or anything like that observed. His stomach is flat. And next we are going to auscultate all 4 quadrants with the diaphragm. Good. And those are normal active. Next we're going to percuss in all 4 quadrants. And I'm hearing some tympany there, which is normal. I'm going to percuss. We have the gastric bubble there. And we also, I would usually assess my patient on the left side. I'm on his right. So at the 10th intercostal space, I would percuss for the spleen. And that is also tympanic. So dullness would indicate some splenic enlargement. Next, we're going to do palpation. We'll start with soft palpation of the abdomen, and that just helps us, or light palpation, it just helps us identify any tenderness, any areas that might cause some guarding, and he does not have any. So then we'll go to a deeper palpation, looking for any masses, bulges, hernias, or anything like that. I'll go ahead and have you lift your head, chin your chest. This is a good way of watching for any muscle separation. You can put your head down, and there's none observed. And sorry. And then I'm also going to palpate for the liver. Go ahead and take a deep breath in for me. And I can feel just a centimeter or so of that liver. I'm going to percuss that liver border. Good. So that's about 6 centimeters, and that's how we would expect our liver to be, about 6 to 12 centimeters. So that's normal. So I'm going to do a bimanual palpation for the kidneys, the liver, kidney over here. I cannot palpate the spleen. I'm going to palpate the abdominal aorta. Go ahead and relax your stomach. Good. I would also palpate the inguinal pulses and the femoral pulses here, but I'm not going to do that to my patient. And I believe, so next we're going to do the superficial reflexes on the abdomen. Oh, we forgot to do that. Okay, superficial reflexes on the abdomen, we would do, we would go in all 4 quadrants, a light touch away from the umbilicus, and we would kind of look for a twitch or a pulse in the abdominal muscles. In the cremasteric reflexes, I would look at, I would do a light stroke to the inner thigh, and I would expect elevation of the testes and scrotum for a normal reflex. And then the plantar reflex, I would have the patient go ahead and sit up. You can sit up now. So for the plantar reflex, I would take something relatively firm, starting at the heel and going lateral to the toes. I would expect flexion in the foot there, and that is normal as well. So we'll next do deep tendon reflexes. Go ahead and, so we're gonna do the bicep, the brachioradial, the tricep, the patellar, the Achilles, and then I would also elicit, go ahead and lay back for just a second. So in the foot, for the clonus, I would have the patient relax their foot and leg, and then I would kind of elicit a quick dorsal flexion, and I would be watching for a rhythmic movement or oscillating movement for that reflex. And his is within normal limits. Okay, I think we officially got our neuro done now. Okay, so we did the abdominal. Now we're going to do musculoskeletal. I'm going to, our musculoskeletal, we're going to first look at we'll do spine and neck last. We're going to do the shoulder. I would be inspecting and palpating the shoulder bilaterally for edema, erythema, any ecchymosis, tenderness, masses. I want you to go ahead and put your arms up like this. If you want to stand, that might be easier. Go ahead and put your arms up and then put them back behind you. So like a hyperextension, good. And then shoulders, I want you to do an abduction with, I'm gonna have you give you some resistance here. So put your arm out like this, okay? And then put it across your body, good. And then do some internal flexion and then external rotation up here, good. Any pain with that?
No.
Great, you can sit down again. So then we're gonna do his elbows bilaterally. I'm going to inspect and palpate the olecranon process for any edema or erythema, tenderness. And then I'm going to look at the medial and lateral epicondyle for any other abnormalities. Next, we're going to do range of motion with resistance. Go ahead and I want you to like flex your arm. So bicep curl, good, push away, great for extension. And then I want you to pronate your arm like this and then supinate. Any pain or tenderness with that. So all of these have been 5 out of 5 for strength, and we would do these bilaterally. Next, we're going to do the hip. I'm going to have you lay back down this way, I think. So for the hip, I'm going to inspect and palpate the hip joints. I'm going to be assessing and inspecting for any tenderness, masses, crepitus, things like that. So for the hip, I'm going to have you go ahead and try and flex your hip like this. Okay, more. Flex up. Good. And then abduct your hip, so push it out. This way, good. And then push, go across your midline body, good. And then I'm going to flex your knee here and your hip, and I'm going to do an internal and external rotation there. Any pain or tenderness with that?
No.
Good. For, I just remembered we forgot to do our abdominal test too. Okay, for hips, I'm just gonna double check one thing. Okay, no, we're good still. Okay, so for the knee, we're gonna do the same thing. I'm going to, whoa, sorry about that. So for the knee, we're going to look and inspect the knee. We're gonna do a range of motion with resistance. So go ahead and flex and pull back on your knee, good. Push it forward, good. And then you can relax. We're gonna look at the bulge test. I'm going to milk medial a couple of times and then laterally push it back. And I'm going to see if there's any bulge that happens in that medial area indicating effusion. The next knee effusion test we could do is the ballottement. So kind of putting some pressure on the knee. I would put some light gentle pressure on the patella and see if it kind of has a floating sensation. That would also indicate effusion. And then we're going to do, you okay?
Yeah.
Then we are going to do a couple of tests. We've got McMurphy's, which is testing the meniscus, and we would be looking for some flexion medially and laterally within the knee, indicating MCL tear. And then for ACL and PCL tear, we could do a anterior and posterior drawer test. So I would put pressure posterior, and then I would also pull forward anterior drawer test. And any give more than 5 millimeters, I think, would indicate ACL or PCL tearing. And then I think that's it for the knee. So we did good there. Ankle, we'll look at the ankle here. I would also look at that joint here for any edema, erythema, ecchymosis, and then we will do his range of motion. I'm going to have you pull your toes back with some resistance, so flexion, and then dorsiflexion. So we've got plantar flexion, and then do this again, dorsiflexion, and then I'm going to have you move your foot in and out, so inversion and eversion, and then rotation. Can you rotate your foot? Good. And then flex your toes, and then extend the toes. Great. Any problems with that?
No.
And then I would also inspect his toes, look at capillary refill, and then look at the MTP joint. Okay, so while we're doing that, I'm also going to look at his wrist and hands. I'm going to have you flex your wrist and then extend it, so push it down, good. And then I want you to flex your fingers and then extend them. Flex your thumb and then extend it. I'm going to have you go ahead and sit up. I'm going to have you do a grip test here. So go ahead and squeeze my fingers, grip strength, good, that's symmetrical. And then we're going to be testing for carpal tunnel syndrome. So go ahead, and this is the Fallon test. I would do this, have him flex his wrist for 60 seconds, and any numbness or tingling would indicate some issues with that. And then the Talon test, I would be tapping in the medial nerve, and any tenderness, pain, tingling, numbness would indicate carpal tunnel as well. And then I would also be looking at the MCP joint as well, and that all looks great. And all of his muscle strength, resistance has been 5 out of 5. So I think we did that. Okay, I want you to lay down again. And we're gonna do your, I forgot to do his abdominal testing. So palpating, rebound tenderness, any positive spots would, indicating pain would be a positive Bloomberg test. And then McBurney's point would be in the right upper quadrant. I'd have you take a deep breath. Good. This is the Murray's sign, or no, Murphy's sign. Is this what this is? Right upper quadrant, take a deep breath. Once that area would hit my fingers, it would indicate some pain and he would suddenly stop breathing in. We've got the lower abdominal sign. Tenderness there would indicate a problem. And then I'm going to do with his right leg. So I'm going to do the iliopsoas. So I'm going to have you lift your right leg for me. Good. Stop. And then any trouble with that or pain with that maneuver would be indicating peritoneal tenderness or problems. And then the obturator. So I would take his right knee and hip, flex those, and we would be bringing those medially and laterally. And any tenderness with that would indicate a positive sign. Okay, go ahead and sit up. We're almost done, I promise. So we did the musculoskeletal. As far as to finish our musculoskeletal, I'm going to look at his legs and feet. We're looking for edema, discoloration, any perfusion problems, I think I said edema, ecchymosis, things like that. I'm going to check his pulses here. We already checked his femoral pulse. We're going to check his popliteal pulse, his dorsalis pedis pulse, and the tibial pulse, and those are all 2+. And we already did the cap refill. Before I do, I'm forgetting something, but we're going to go ahead and do the breast exam also first. Oh, let's do our posterior landmarks. Go ahead and turn this way. So our posterior landmarks here, we have the 12th rib, the 7th rib, we have the spinous process, and I have already assessed for the paravertebral muscles. We've identified the C7 T1 prominent point here. We've got the intrascapular area, the costal vertebral margin, costal vertebral angle. We have the mid scapular line. And then as far as the neck and spine for musculoskeletal, we already did his movements in our neuro exam. For this musculoskeletal, go ahead and stand up. We're going to do that quick. We're going to check for scoliosis. So go ahead and stand and bend forward, your hands to the ground. So we would look for spine and neck alignment here, and everything looks great. Go ahead and stand up. So I would have you bend backwards, so like hyperextend this way, good. And then I want you to laterally move side to side, good. And then rotate your spine. Any problems with that?
No.
Okay, good. Go ahead and sit. Okay, so for lastly, the breast exam, we're going to inspect the patient's breasts while they're sitting up. Of course, they would be undressed for this. I would be looking for any bulging signs or signs of bulging, masses, lesions, dimpled skin, orange peel skin, discoloration, erythema, edema, things of that nature. With a good light source, I would have the patient, I would be looking bilaterally. So we're looking size, shape bilaterally. We're looking at the nipple, size, position, any lesions, anything like that. So with my light source, I would have the patient raise their arms above their head. And then I would have the patient put their hands on their hips and then contract their muscles and then lean forward. Good. So now, then I would go ahead and you can lay down. So then when they're laying down, I would also look for all of those same things, inspecting while they're laying down. I'd be looking at the nipple placement, any discharge, things like that. Then I would palpate. So when they're sitting up, I would palpate from the clavicle line to the inframammary line, and I would go up into the tail of Spence, in the axilla, all the way to the post-axillary line. And then when they're laying down, same thing. And then I would sweep from the clavicle to inframammary line. And then while they're laying down, I would do in small circles, I would go over all of that from the sternal line all the way to the mid-axillary and post-axillary line, making sure to cover the axilla, the tail of Spence, and under the arm and on the lateral side bilaterally. Then I would palpate the nipple. And then I'm also going to inspect for the lymph node enlargement and palpate the lymph nodes. We're going to be looking at the infraclavicular and the supra and infraclavicular lymph nodes, as well as the central and lateral lymph nodes, the pectoral lymph node, and the subscapular lymph node. And that concludes our exam.